Dear students, as part of the paper on fertility, this module focuses on caesarean deliveries, its issues and concerns. When we see the reproductive health, the natal care along with antenatal and postnatal care occupies an important place in the reproduction, and accordingly we need to understand what are the delivery practices and how the modern technology is helping in these issues. The learning objective of this module is to focus on the caesarean deliveries and the major issues that comes around it and the concerns that comes out when we are focusing on the type of deliveries like caesareans. Caesarean deliveries mean the childbirth occurs through surgery. A caesarean delivery is a surgical procedure in which a fetus is delivered through an incision in the mother's abdomen and uterus. Fetal indications for caesarean delivery include the following: situations in which neonatal morbidity and mortality could be decreased by the prevention of trauma, malpresentations, example preterm breech presentations, non-frank breech term fetuses, certain congenital malformations or skeletal disorders, infection, prolonged acidemia. Indications for caesarean delivery that benefit the mother and the fetus include the following: abnormal placentation, abnormal labor due to cephalopelvic disproportion, situations in which labor is contraindicated. The number of caesarean deliveries or C-section surgeries have increased in the country, which is a matter of concern for all. Among the developing countries until recently, the high rate of this form of delivery in the Latin American countries was a cause of concern. Good reproductive health implies that the couples are able to have a satisfying and safe sex life, and that they have the capacity to reproduce and the freedom to decide if, when and how often to do so, as defined by Indian Council of Medical Research 1999. Safe motherhood, which includes direct and indirect efforts, plays major role for safe and secure pregnancy and delivery. The prenatal, antenatal and postnatal care for the expectant mother is an important part of normal and safe delivery. Promoting vaginal delivery not only reduces the likelihood of complicated delivery practices, but also in future deliveries. Delivery by caesarean sections have become underspread in the country. For instance, in Andhra Pradesh, that many of the deliveries that would have or should have been normal are subjected to caesarean sections for various commercial reasons. When the baby has to be surgically removed from the mother, the procedure is called birth by caesarean delivery. As with any medical procedure, caesarean delivery involves a degree of risk and recovery and is performed if the health and welfare of the mother and infant are jeopardized. The appropriate use of the caesarean section procedure has become a compelling issue of quality of care. The caesarean delivery occurs in certain conditions like cephalopelvic disproportion, fetal stress, abnormal presentations, breech presentations, placenta previa, abruptio placenta, cord compression and maternal complications. The caesarean section can be avoided at certain levels. There should be proper communications between gynecologists and caregivers with the woman who will deliver the baby. Making important decisions in time for delivery depends upon both medical person or caregivers and mother or her concerns. Complications may arise that will require that one should make important decisions regarding the birth of their child, such as whether to proceed with a caesarean birth. There are few reasons for caesarean delivery, such as health risks like previous caesarean birth with a classical incision, ineffective contraction, contraction with failure to progress into labor, very premature infant, maternal cardiac condition, uncontrolled diabetes, high blood pressure, pregnancy induced hypertension, prolonged rupture of membranes beyond 24 hours, multiples like twins or triplets, active case of genital herpes. Besides these medical reasons, certain factors related to institutions and physicians have also been found to be associated with high caesarean section rates. The physicians, factors that affect caesarean section incidence include physician practice styles, experience in handling the situation, etc. Active participation by patients should be encouraged to arrive at a safe, logical, informed decisions about the method of delivery, with the carer recommending what they perceive to be the best course of action in keeping with the available incidents. A trained gynecologist cannot decide without properly assessing the condition of the woman and proceed to caesarean section. In recent years, the rate of caesarean section has increased at a appalling rate for various reasons all over the world. There are certain risk factors involved with caesarean section. They include severe blood loss requiring blood transfusion during surgery, which is an important area of concern, where caesarean hysterectomies are done. Usually there are wound infections and wound dehiscence, increased morbidity requiring prolonged hospital stay, anesthetic complications, hemorrhage, bladder bowel injury during hysterectomy, etc. Late complications like incisional hernia and higher incidence of problems like placenta perfida and placenta accreta have adverse impacts on breastfeeding and negative psychological impacts of caesarean section on mothers. Several studies have reported a statistically significant increase in maternal health complications, specifically infectious morbidity for caesarean section cases compared to planned vaginal delivery. Babies born by caesarean section are often subjected to high risks of morbidity, including fatal injury and fractures. Source: Alexander et al., 1987. There are incidences of HIV transmissions through blood to mothers, and this may whole family is affected by HIV. Besides, biomedical factors, demographic, socio-economic, spatial and psychological factors also influence the frequency of caesarean section deliveries. The birth weight of the infant also plays a major role in the case of caesarean deliveries. The mother's education and living conditions are other important factors which affect the likelihood for caesarean section. In a study conducted in Brazil, Chacon and Perpetuo in 1998 have clearly documented the association that exists between maternal education and type of deliveries, particularly caesarean section. The social factors like family support system are highly essential, and prolonged dependency of mothers is an unfortunate factor. The breastfeeding and colostrum feeding of newborn child will affect the health status of the child. The hospitals, especially the private health centers, charge heavily for conducting caesarean section deliveries. The caesarean sections are in demand mainly due to status conscious of the people, as it indicate their better financial conditions, to avoid labor pains, and beliefs in auspicious times and date to give birth to the child. medical personnel and nursing homes explicit the social and cultural factors. The various factors affecting caesarean section were brought out in different studies. For instance, Stevens 2002 in his study on caesarean section on demand dilemma of the obstetrician shows that the unnecessary caesarean sections are conducted mainly due to doctors' encouragement and women's demands. Mukherjee et al. In 1993 have studied about prenatal mortality in caesarean sections, a disturbing picture of unfulfilled expectations. They showed that caesarean section is a major operative procedure which carried considerably more risks to mother even in developed countries. In the United States, caesarean section deliveries were found to be constantly increasing from 16% to 20% during the survey period, reaching 23.6% by 1991 as reported by Toffel, Plasek and Moynin in 1985. Nadraj 1994 in his study on quality of private health care has inferred that though the private sector in healthcare is large and growing, it is poorly regulated with hardly any regard to quality. In addition to it, the doctor's charges are more often than not exorbitant and irrational. Expectant Mothers Guide to Philadelphia of year 2002 shows the various reasons for caesarean delivery and its avoidance. Mishra and Ramanathan in the year 2002, while analyzing the cases whether it was an elective or an emergency caesarean section, have identified the reasons for the choice in their study and the determinants of caesarean section rates. The incidence of caesarean section deliveries is reported to be higher in private health institutions when compared to that in government hospitals. Kannan et al. 1991. Risk adjusted caesarean section rates for California hospitals during 1995 to 1997 report in 2002 show that variations in risk adjusted C-section rates across geography, payer resource and provider type have created concerns that the decision to perform a caesarean section was not always based on clinical factors alone. The White Ribbon Alliance for Safe Motherhood, India 2002 shows various steps to avoid risks during delivery and for safe motherhood. Padmadas et al. In 2000 were of the view that information related to pregnancy and health related aspects needs to be monitored more accurately both in public and private hospitals to understand the determinants associated with the caesarean sections. Mutrin 1993, based on his study of maternal and paternal psychosocial outcomes, has assessed the psychological impact of caesarean section in the family. Mulder 1993 showed high rates of caesarean deliveries in developing countries. According to World Health Organization 2015, since 1985, the international healthcare community has considered the ideal rate for caesarean sections to be between 10% and 15%. Since then, caesarean sections have become increasingly common in both developed and developing countries. When medically justified, a caesarean section can effectively prevent maternal and perinatal mortality and morbidity. However, there is no evidence showing the benefits of caesarean delivery for women or infants who do not require the procedure. As with any surgery, caesarean sections are associated with the short and long term risks which can extend many years beyond the current delivery and affect the health of the woman, her child and future pregnancies. These risks are higher in women with limited access to comprehensive obstetric care. Strange et al. 2016 showed the factors associated with the caesarean sections in Phnom Penh, Cambodia. They observed reasons that before labor, reasons for requesting a C-section were choosing the delivery date, bringing luck and joy to the family, protecting the genitals, and the belief that C-section is safer for the mother and for the baby. Reasons given during labor were fear, pain, and having no more energy. We also observed two major factors driving the woman's request for a C-section, that is, family support for requesting a C-section and the overusage of ultrasound examinations. Chechen and Perpetuo 1998 showed the incidence of caesarean deliveries in Belo Horizonte, Brazil, social and economic determinants. They discussed that independent of women's education, age or parity, doctors who work in the private health sector with private or insured patients are much more likely to perform caesarean deliveries. Although other demographic factors like parity and age have some influence on the caesarean rate, the type of hospital where woman gave birth was the most important determinant of the incidence of caesarean section. To have a baby in a private hospital instead of a public hospital was the most important risk factor in determining whether a caesarean was likely to take place. Palladino et al. 2017 explained the relation between caesarean birth and child cognitive development. Kelly et al. 2010 have explained that recovery after caesarean birth, a qualitative study of women's accounts in Victoria, Australia, they inferred the women in this study reported a range of unanticipated and unwanted negative physical health outcomes following caesarean birth. Zecher-Hamidi et al. 2015 discussed on vaginal delivery versus caesarean sections. A focused ethnographic study of women's perceptions in the north of Iran, they inferred that in the north of Iran, women's justified cultural beliefs overshadow their misconceptions. So, it is hoped that through implementing appropriate training programs for raising awareness and correcting misconceptions, vaginal delivery could be promoted even in regions with high rates of caesarean sections. Toffel and Plasik in 2011 explained various complications in caesarean and non-caesarean deliveries in United States. Perez Escamilla et al. 1996 explained the association that exists between caesarean deliveries and breastfeeding outcomes among Mexican women. It is desirable to provide additional breastfeeding support during the early postpartum period to women who deliver via caesarean sections. Kai et al. 1998 explained increased caesarean section rates and emerging patterns of health insurance in Shanghai, China. The trend of increasing caesarean section rates is a problem in itself, but more important, it may indicate that China is headed toward a more costly technology driven medical care system. Guzman et al. 2015 explained high caesarean section rates in Latin America, a reflection of a different approach to labor, that advocacy for patients and their well-being is of paramount importance, and that approach to the Latin American labor patient should be human, supportive and based on evidence. It is well established that maternal and perinatal outcome are linked strongly to good obstetric practice rather than caesarean sections. This has been confirmed recently in a World Health Organization's 2005 global survey done in 8 countries of Latin America. In developing countries with a poor infrastructure, lack of well qualified manpower and non-availability of blood, both mortality and perinatal morbidity and mortality and the woman's future reproductive performance are a cause of concern. The decision to perform a caesarean section must be maternity centered and not technology centered. Marathe and Mukadam 2017 showed profiteering hospitals are driving alarming rise in caesarean section deliveries in India. According to them, as per provision of the Medical Council Act, doctors are supposed to declare the number of caesarean sections performed in a particular span if the information is sought. However, there seem to remain on paper. In addition to this, all hospitals should maintain records of the condition of the mother and the baby during labor. This will help to guide doctors about decisions regarding normal deliveries and caesarean section deliveries and help in monitoring the practices. This could be part of the standards of the Clinical Establishments Act. Secondly, the government should standardize rates for normal and caesarean section deliveries, which could also be linked with the Clinical Establishments Act. This will help avoid doctors urging patients to opt for avoidable caesarean sections. Emphasis must also be placed on educating pregnant women about normal deliveries and the implications of having a caesarean section. Education about pregnancy and a healthy lifestyle is a good way to avoid increasing your chances of delivering via caesarean section, according to Goyal 2017. Maneka Gandhi in 2017 suggests to make it mandatory for hospitals to publicly display the number of C-section surgeries and normal deliveries carried out in that area. Newman et al. In 2014 discussed prevalence and determinants of caesarean sections in private and public health facilities in undeserved South Asian communities, cross-sectional analysis of data from Bangladesh, India and Nepal. Their study found that delivering in a private health facility was associated with the increased odds of caesarean section in 3 of 4 South Asian locations, and that the associations persisted after adjustments for maternal, pregnancy and delivery characteristics and year of delivery. We also found significant interactive associations between maternal education and caesarean deliveries in Bangladesh, private as well as public facilities, and urban India like in private facilities only. In conclusion, we may draw upon from the module which focuses on caesarean section as follows. Though caesarean section deliveries are performed all over the world, the risks involved in it is of common concern. Moreover, there are indications that the caesarean rates are rising steadily in developing countries. There are very limited research works carried out in this regard as to why, how and where deliveries on caesareans are really needed. There is a need to conduct studies by focusing on various social, economical, demographical, cultural and medical factors which are contributing to caesarean sections of deliveries. Understanding the various factors contributing for this practice in different regions of the world helps significantly to take various steps to avoid this practice for the well-being of the expectant mothers. Such studies are also expected to throw light on health practitioners scenario both in public and private sector, and quite useful at policy level and implementation of various programs which are meant to improve the reproductive health of the woman in the community. And thus, when we promote the caesarean deliveries, we also should be more responsible, and also wherever it is required, such practices have to be taken into consideration, but at the same time its misuse should not be encouraged, and effective regulatory mechanisms have to be placed for its effective implementation, so that at the end of the day we need to know that as part of good scientific and effective reproductive health practices in our country, such deliveries through caesareans should act as a major contributory factor, and such acts also should be kept in mind for promoting the scientific way of deliveries in our society.